talking about cardiac electrophysiology. So we're going to build on the things that we've learned, especially in Unit 1 with like our action potentials. We're going to build on what we know with cardiac muscle and kind of learn how we generate an EKG. I know the AA students already have an EKG course going on right now. PA, you'll get a full one in the fall. So we're just going to kind of just touch the basis of what EKG is and how our heart works. Okay, so let's go over the conduction of the heart. First thing, we have certain parts of the heart, and you can see up here, let me change the color. 99% of our heart is contractile muscle. 1% is autorhythmic, meaning only 1% of the tissue of our heart has electrical properties. The majority of it is just muscle. And remember, what does the heart have as far as in its cells that allows for the heart to act as one unit? Gap junctions. What's that fancy word? Syncytium or syncytium, that the whole entire heart is going to act as one once any one little cell depolarizes. So, what does that mean for the heart? The fastest cells that will depolarize will control the entire heart, because we know that once one cell depolarizes, the whole heart is going to go. In our heart, we have a very specialized area up in the right atrium, and I'll put it in a different color. We have one collection of cells up here, and that's called your SA node, sinoatrial node. If you ever hear anything on a EKG called normal sinus rhythm, that means that every single beat of that heart originated from the sinoatrial node, the SA node sinus rhythm. So the SA node is the first little electrical area that we have. The next part is right in the little area right here by the septum, and that is called the AV node. Atrioventricular node, AV node. The reason why this is important we'll get to in a little bit. The AV node is also known as a capacitance node. What does a capacitor do? Electrically speaking, anyone know what a capacitor is? Hold on to a charge. That's all the AV node does, is it holds on to the charge for a quick little second before it sends it off to the ventricles. With our heart, we have an area, let me change the color to black. Kind of like this. If you take right where the valves are, that area has some tissue that's pretty much just cartilage, that our valves are made up of cartilage. This area does not conduct any electricity at all. The only way you can get from the top of the heart, from the SA node, electrical signal to the bottom of the heart is through the AV node. Once the AV node gets depolarized, it's going to hold on to that charge before it sends it down the road, down the ventricles. What's the first little area that it's going to depolarize for electrical activity of the heart? As you go down from the AV node, what's the next one? Bundle of His. Or His bundle. Then, as the impulse comes down, we have two branches. And these are the bundle branches. We have a left one, we have a right one. Then, as it comes down, and you can see that in yellow, let me just make this bigger. Okay. As these impulses come down, they go up the ventricles, and then you can see all the yellow inside. Those are the Purkinje fibers. That's that last little bit. All these Purkinje fibers are all innervated in the ventricles so that your ventricles can squeeze appropriately. Remember, excitation, contraction, coupling. We have to excite the heart first, then it will contract. So these depolarizations that are occurring are going to happen before we contract. Yes? I gotta figure it out. Are they coming on back? Okay. Let's see if there it is. And is this one on? There we go. Okay. So when you're studying, if I'm going to tell, so know what the order of hierarchy of these pacemakers are called pacemaker cells or autorhythmic cells. SA node to the AV node, bundle of His, bundle branches, Purkinje fibers. That's the order it's going to take. Now, the AV node is a capacitance node we talked about. It's going to hold on to the charge before it sends it down the line through the bundle of His and all that stuff. Why do you think it's important that there is a delay between the atria and the ventricles? We have to have time for the ventricles to fill with blood. If the impulse was too fast, there's not enough time for the ventricles to fill before they squeeze and contract. So by having that delay in the AV node, it allows the ventricles to fill, so you're not just pumping air. You're not going to ever pump air, but as an example. You want to make sure those ventricles are filled, and the AV node will do that. Okay. So let's look at the action potential now. So we have millivolts. So we have that is going to be obviously your membrane potential. And remember, along the x-axis is time. Our heart is a timed cycle. It's called a cardiac cycle because it cycles. If your heartbeat is 60 beats per minute, how fast is your cardiac cycle? 1 second. If it's 60 beats per minute, means every second your heart's beating, that means you're depolarizing your heart 1 second. It takes 1 second to get to the whole thing. So X is always time, the Y is our memory potential. The dashed line is our threshold. What number is threshold usually? Threshold, negative 55. Okay, so that's what a dashed line means. So the first thing to always happen, I'm going to put them in different colors. So phase 4 is the ground, and nothing is going on with phase 4. This is our normal, everything's at rest, no channels are open yet, and we're at baseline. Now, we're going to depolarize. Okay, and we're going to call this phase 1. We're going to creep up to threshold. Once we hit threshold, we go right up. And this is our depolarization. Just like we learned in general phys, what is the ion responsible for depolarization? Sodium. Still sodium here. So dipole is still going to be sodium. Then, when we get to the top, we have a very, very minor start of a repolarization. But What was special about the cardiac contractile apparatus, the whole thing? What makes the cardiac muscle different than skeletal muscle? Calcium, right? Remember, what was it called? Calcium-induced calcium release. The calcium that's being induced, where's that coming from? Outside the cell, voltage-gated channels, it comes in. Once it gets in, it causes the calcium-induced calcium release to come from where? Sarcoplasmic reticulum. Then you get that spike of calcium, a lot of calcium going on in the cell. Now, I've stated we started doing our depolarization, our repolarization, right? Because at the top, what channels open up? Potassium. Remember, we have our potassium gated channels, and they open up at the top. Potassium. Which way is potassium moving? In or out? Out. Which way is calcium going? In. What charge is potassium? Positive. What charge is calcium? Positive. So we have positive coming in, positive leaving. What do you think is going to happen to our net charge? Stays the same. So we have a plateau phase. Plateau phase, and that's caused by calcium. The calcium movement causes the plateau phase. We're not going to a full repolarization like we have in our nerve cells because they don't have the calcium there. So the calcium-induced calcium release causes the plateau phase. Then we have to get rid of the calcium. How do we get rid of the calcium? There's two ways to get rid of the calcium. Where do we put it? Back in the SR, or we get it out. How do we get it back into the SR? What's the pump? Calcium ATPase pump gets it back into the SR, and that sodium calcium exchanger gets it out of the cell. So both of those things kick in. Calcium is done now, but what ion is still moving because their doors are still open? Potassium. So calcium is done now. Now it's potassium's turn. What's going to happen to the action potential? It's going to repolarize because only potassium is leaving the cell. So all this positive ions are leaving. Inside's going to go back to normal rate. And let me change the color one more time. And we have our repolarization phase. And then, as we go back down, we go right back to our ground phase 4. So, action potential depolarization is still caused by sodium, just like we learned before. We have a plateau phase, no net movement of charge because positives are leaving and positives are coming in. Plateau phase is calcium regulated. And then finally, our repolarization is due to potassium. This is the way it always is. Just get this in your brain and memorize it. It's always going to be that way for cardiac. This is cardiac muscle. And what percent of the heart is cardiac muscle? 99%. So 99% of our heart is going to do this. Luckily, they do it for us. You don't have to think about having your heart beat or anything or squeeze harder. We take care of it. Your body takes care of it for you. So this is an action potential for a ventricular or an atrial myocyte, the muscle contraction properties of the heart. They all follow this pattern. Any questions on this one? Okay. So remember, this is muscle cells. This is not the autorhythmic cells. We're going to talk about the autorhythmic cells in a second. Everyone good on the ventricular muscle action potential. Okay. So this is what we just drew. Phase 4 is right there, that resting memory potential. Nothing's happening. We're at that baseline. Then we get a stimulus. Action potential happens, which is phase 0. Sodium dependent. Phase 1 is that partial repolarization phase, happens very, very fast. Phase 2 is the plateau phase. That's calcium. Phase 3, full repol, is due to potassium. Yes?
First is -9
70. I mean, it doesn't matter. You don't have to know it.
Okay, that's not.
Yeah, don't worry about that.
Okay.
So that's where we're at for the ventricular muscle action potentials. When you get to the autorhythmic cells, here's your SA node. Okay, SA node, you don't need to know the phases as much as you do for the ventricular one. The important thing about the SA node potentials, they depolarize spontaneously during phase 4. Okay, that's why it's our pacemaker cells. They randomly and spontaneously depolarize because they have very, very weird, funky sodium channels. They just don't go into great detail about it. Just know they have funny sodium channels that allows it to keep depolarizing spontaneously. So phase 0, which is the depolarization, we're going up, is slow, meaning if you were measuring the steepness of a curve, a slope, the ventricular cells will depolarize straight up. That is a fast depolarization, straight up. The myocytes will depolarize like that. That's slower compared to the red one. Everyone can see that. The red one depolarizes fast. It goes straight up. The purple one, which is the SA node, is a slower action potential. It just happens that they occur more frequently. So the SA node has a slow depolarization speed, but a faster rate of depolarization. And I'll have a graph to show you that, what I mean in a second. The rate of depolarization is how many times a minute is it going to depolarize. The speed of the depolarization is how fast does it go, that all or none principle. The SA node, because it depolarizes at a faster rate than any cell in the heart, it controls the heart rate. Remember, all or none principle. If any cell in the heart depolarizes, the whole heart goes. Luckily, the SA node fires faster than everything else, so it controls the heart rate. If the SA node fails, the next one that has the higher depolarization rate is the AV node. So then the AV node takes over your heart rate. If that fails, then your ventricles take over and your heart rate gets really low. And we'll go through that in a second. It's called the hierarchy of pacemakers. So that's the SA node. Now, let's do a little magic trick here. We talked about autorhythmic depolarization and how it looks. It doesn't have that plateau phase. So if we looked at just the SA node depolarization by itself, it'll look something like that. That's the autorhythmic stuff. Now we have to have the ventricular myocytes depolarized to actually squeeze. We have a rapid depolarization, partial repol, and then we have the flat plateau phase, and then we have repolarization. That is what an EKG is. First part, we call it a P wave. Just means that the SA node fires. This right here, we call it a QRS. That means the ventricle's contracted, depolarized, and we call this one the T wave, and that means the ventricle's repolarized. That's all an EKG is. First part is just looking at the atrials. Second part is the ventricles. The last part is ventricular repolarization. Atrial repolarization does occur, just that it gets embedded in the QRS and you can't see it. But it's all there. But that's how an EKG looks. That's pretty much all we're going to do for EKGs. We're not going to go crazy. This correlation right here, again, reinforcing ideas that we learned about. We give drugs, and they're called antiarrhythmic drugs. We don't want them to have bad heart rhythms, and they can alter those phases of the action potential. Class 1 drugs affect sodium channel blockers. If you're affecting the sodium channels, what phase is going to be affected? The depolarization. You can have problems with that. Beta blockers we talked about before. Potassium channel blockers. Where is that going to have a problem or cause an effect in the heart? Repolarization, because that's where the potassium is moving. Calcium channel blockers. Plateau phase and other things that go along with that. So again, you don't have to memorize this for your exam. You will get it in pharm. But just to show you, this is why we give these medications, because we can alter these action potentials. Okay, so these hierarchy of pacemakers. SA node is a pacemaker because it most rapid depolarization. It controls the entire heart rate. So normal sinus rhythm, SA node through the rest of the conduction pathway. The intrinsic rate, I mentioned yesterday, if you cut off all neural input to the heart will beat at the SA node intrinsic rate of 100 beats per minute. But we have parasympathetic tone, so it brings it down to like 70 or 80. When normally on rest and digest, the parasympathetic is in control, brings our heart rate down. If the SA node fails, AV node takes over, and the AV node has an intrinsic rate of 40 to 60. If that fails, bundle of His will take over, and that rate is only 20 to 40. So if someone comes in with an EKG and their heart rate's in the 30s, you don't see any P waves, you might have a problem with the top part of the heart versus the bottom. That's all you're looking at. So as one fails, it goes to the next one. Don't worry about this one. Okay, refractory periods. They are here again. We did mention them before. Why do we have an absolute refractory period? What's still going on? Sodium channels have to reset to their normal settings. They haven't got, not all of them have gone yet, so we have a refractory period. Any additional action potential can produce arrhythmias, so that's why we have to be very careful with excitation of the heart. We don't want those premature ventricular beats, extra heartbeats thrown in there. If the ventricular rate is too high, again, we talked about, we don't have enough filling time. Remember, 1 second is all you get at 60 beats per minute, and the higher your heart rate goes, that time gets smaller and smaller. If you're at 100 beats per minute, now you're like a full entire cardiac cycle is in like half of a second. So you have half of a second to get all the blood moving through the heart, squeezed, everything to keep your blood pumping through your whole body. So ventricular muscles have a very long absolute refractory period from the onset of phase 0 through phase 3. This is important to protect us against re-entry rhythms, meaning when you have an abnormal beat in the ventricles, it comes up to the atria and starts cycling on itself, causing very, very fast heart rates. So that refractory period helps protect against these bad arrhythmias. And obviously we can alter that with beta blockers and calcium channel blockers. Okay, here is the AV node. Remember we talked about that being a capacitance node. Okay, it's going to hold on to the charge. Helps protect against rapid atrial arrhythmias going to the ventricles. What is atrial fibrillation? Anyone know? Atrial fibrillation is when the atria fibrillate. They're just beating 300 to 500 beats per minute. They are flying. Atria are going like crazy. Ventricles will just kind of like go along for the party and just beat whenever they want to. The reason that AV node is so important is because all these conductions that get to the AV node, how does it know if this is a real beat or this is a abnormal one? It doesn't. So by having this long capacitance node, it blunts so that only some beats get through. You don't want your ventricular rate to be 300 to 500 because then your heart will just explode. So the AV node protects your heart from going crazy fast when you have an atrial issue. Okay, so that's, again, why refractory period is so important. Here's just another way of looking at it again. Remember why we have the absolute. Sodium channels haven't fully reset yet. The relative refractory period, enough sodium channels have now reset, where if an impulse comes along, we can depolarize. That's the relative. So, autonomic regulation of the heart. We know that parasympathetic is mainly dominant when we're at rest. Parasympathetic is going to be your vagus nerve. Remember, it's parasympathetic, so it's always going to be acetylcholine. In the heart, we use muscarinic receptors. And it's going to cause negative things. Chronotropy is time. Dromotopy is conductance, I think. Inotropy is contraction. So you don't have to go crazy with those. Just know, obviously, sympathetic system, your alphas in your betas in your heart. Norepinephrine is the main neurotransmitter for the sympathetic system. We're going to speed up conduction through the heart, increase the heart rate, increase contraction. Remember, fight or flight. We need more cardiac output. Everything needs to go up. Parasympathetic calms things down, relaxes the heart rate, relaxes the contraction, slows conduction through the heart. So this is what I was talking about before with the rate of depolarization. Are these autorhythmic cell depolarization, or is this myocyte depolarization? These two lines here. Autorhythmic. Why are they autorhythmic and not ventricular? There's not straight up, and there's no plateau phase. Plateau phase is due to the calcium in the skeleton, in the cardiac muscle. Autorhythmic cells don't have that property. Now, look at the slow rate. How many depolarizations do you see in the top row? 4, right? 4 in that same period of time. Now, faster heart rate. It's going to depolarize faster. How many do you see now in the bottom one? There's 5 now, which means it's depolarizing faster. That's what I meant by the SA node will have a faster rate of depolarization, but the speed of the depolarization is not straight up. It's on an angle, so it's a little bit slower. So that's what I was talking about with active potentials versus in the myocyte versus the autorhythmic cell. Myocyte, fast depolarization, but slow rate of depolarization. How many of those depolarizations are going to happen in a minute? In a ventricular cell, 20. That's all. So the SA node controls the entire heart. If you ever need a pacemaker, we put one of the wires right in the right atrium so it can mimic our normal conduction patterns. So that's what I was talking about with the SA node. So this one, we'll skip this one for now. You can look it on your own. I'm not going to test you on anything with the EKG stuff. QT interval, skip all this stuff. Skip this too. I don't want to get crazy with EKGs. But basically, a 12-lead EKG is instant replay in football. That's all you got to think about it. They're all cameras looking at the same image with different point of views. So every lead that you see, think of it as a camera looking at the heart. Camera's going to look at certain parts. So this is all the same play, but different angles. That's what a 12-lead EKG is. Brittany knows this one. I put it in there because of her. That's what an EKG is, 12-lead. Different images of the heart. Some look at the heart from an inferior perspective, some from an anterior, some lateral. But they're all looking at different parts, and if any part of the heart is damaged, you will see it in the specific parts. So this is what a 12-lead looks like. Again, you can see the labels right here, but again, those are just different cameras, different ways to look at the heart. So that's it for cardiac electrophysiology. Now let's move on to the cardiac cycle. We talked about how the heart depolarizes. Now let's talk about the actual contraction of the heart and what happens. So there's a video you guys can look at later on. Kind of puts it all together. So cardiac cycle, electrical and mechanical events, the excitation, contraction, coupling, all goes together. All those ECG waves correlate with a muscle contraction. The P wave will precede atrial contraction. So every time you see a P wave, you know the atria contracted. The PR segment, which is between the P wave and the actual QRS complex, no electrical activity happens, but this is why the AV node works, because it's holding on to that charge. The longer this PR segment means you have damage to your AV node, because that's the part of the EKG that's responsible for the AV node. QRS complex precedes any ventricular contraction. The T wave, which is really looking at deep repolarization, but in a mechanical sense, the excitation is the relaxation or the repolarization. The mechanical event is ventricular relaxation. So the heart is relaxing. It's in diastole. We've already squeezed, which is systole. Now we're in diastole, and now we're filling with blood. So we need time for all that. So let's go over some more words here. Ventricular diastole. We are filling. Okay, atria and the ventricle are relaxed. Mitral and tricuspid valves are open, and we're filling our ventricles passively. There's higher amount of pressure in the right atrium because they got blood in it, less in the ventricles because we just squeezed it all out. So pressure is gradient. Blood's going to go from the atria into the ventricle. Ventricles fill passively. Atrial systole. Right at the end of atrial systole, there's a little bit of a kick. It's called an atrial kick. It's the last little bit of the atria squeezing, trying to get that last little bit of blood out of the atria into the ventricles. So you'll see that's also called an atrial kick or atrial systole. Helps get that last little bit of blood into the ventricles. Now, ventricles are now filled with blood. We have what's called isovolumic. What does that mean? Same volume. So the volume isn't changing. Ventricular contraction. So the first phase of systole is called isovolumic contraction. This is when the ventricle is starting to generate pressure. It's starting to squeeze. It's compressing the blood. And it's building up pressure. But the volume isn't changing. This is the first phase. None of the doors are open. We're going to refer to the valves as the doors. We have to get the door open. So all we're doing is building up pressure. Once the pressure in the ventricle exceeds the pressure in the aorta, because remember, we have to open up what valve to get out of the ventricle, left ventricle? Aortic valve. We have to open up that valve. So we have to generate enough pressure in the ventricle to overcome the forces on that aortic valve. Once we generate enough pressure during isovolumic contraction, we push open that aortic valve and we get ventricular ejection. Now the blood is leaving the heart, go into the entire system. Blood's leaving the heart. What's going to happen to the pressure inside the ventricle? Because now we have all this blood leaving. It's going to drop. It's going to get lower. Once the ventricular pressure, we're going to graph all this out. So I know I'm just talking about it, but we're going to graph it out. Once the pressure in the ventricle is lower than the aortic pressure, what happens to that aortic valve? Closes, because its pressure is lower. Now we have isovolumic relaxation. All the doors are closed. Mitral valve is closed. Aortic valve is closed. So every time you see isovolumic phase, all the doors have to be closed. Mitral and aortic. We only refer to the left side when we discuss all this stuff because the right does the same thing, just at lower pressures. So we only really refer to the left. So aortic valve is closed. Mitral valve is closed. The pressure in the ventricle is dropping. It's isovolumic relaxation. Pressure is dropping, getting lower and lower and lower. What pressure does this value, left ventricle pressure, have to get below now? When do we know we're stopping with isovolumic relaxation? We have to get below what pressure? Atrial pressure. Once the ventricular pressure is lower than atrial, what happens to the mitral valve? It opens up again, and we start filling the heart with blood, and the whole cycle repeats itself over and over until you die, essentially. Keeps going. Okay, so we're going to draw it out. Okay, in this diagram called the Wiggers diagram. Very, very important diagram. Study the diagram the most. If you can understand the diagram going left to right and up to down, very, very good, solid background. So, what is the Wiggers diagram? It combines a bunch of different values. We get EKG events showing up on here. Pressure changes in the ventricles and the aorta. Volume changes via echocardiography. And obviously you get your heart sounds, and the whole thing is put on it. So, what time is it? Okay. All of these things just describe the Wiggers diagram. So we're going to skip these slides because all they're doing is describing what we're going to talk about. Actually, let me go through it because I want to talk about these things. Yeah, I better talk about these. Okay, we'll go through it. Okay, so left ventricular pressure. Remember, all we're worried about on this diagram is always going to be left side of the heart. Okay? At the end of diastole, we're only at about 0 to 10 millimeters of mercury in the ventricles. Why? Why is it so low at the end of diastole? We're trying to fill. There's nothing there yet, so we're trying to fill. Aortic valve opens when left ventricular pressure is just barely exceeds the aortic pressure. We get a forceful contraction, and that gives us our peak of 120. That's why when you measure your blood pressure, you get a higher number, because we have to overcome the aortic valve to get out. Left ventricular pressure then decreases, and when it decreases below aortic blood pressure, the aortic valve closes. And then again, it keeps dropping and dropping until it's lower than the atrial pressure. Then the mitral valve opens up, and the blood goes into the ventricle. Aortic pressures. Okay, when the aortic valve closes, some of the blood, remember how the aorta is shaped? It's like this. So the blood leaving the heart has to go that direction. When the aortic valve closes, some blood will come back, and it hits that aortic valve. When it hits that aortic valve, it's called a dicrotic notch. So you may see on the phonogram, you'll see a little bit of a notch there. That's what it's referring to. Blood comes back. So your diastolic blood pressure is the aortic pressure just before the next ventricular ejection. So when you measure a blood pressure on someone, you have a systolic number and a diastolic number. The systolic number is the amount of pressure the heart is generating to get the blood out. So with high blood pressure, that means the heart is going to generate, let's say your blood pressure is 170 over 100. That means that during ventricular systole, the heart has to generate enough pressure to get to 170 millimeters of mercury. And that's where that number comes from. That's the amount of pressure that has to get out. When everything closes and the aortic valve closes, remember, the cardiovascular system is a closed system. So even though the pump is off, we're not beating, we're relaxing our heart, there's still blood in our entire system. And that blood that's just normally in our system is your diastolic pressure. So when you go home tonight, you go to wash your hands. Before you even turn on the faucet, there's pressure in your pipes. That is your diastolic pressure. The pump is off, but you know there's pressure still in the line. When you turn on the faucet, then everything flows out. That is your systolic pressure when the faucet's on. That's systolic. When it's off, diastolic pressure. Left atrial pressure is also going to be mapped on there. Normally, it's no greater than 10 millimeters of mercury. Okay. There are some peaks identified, and PAs, you got to know this because it's going to be on your PD stuff when you get to cardiac. There's an A wave, and that's generated by the atrial systole. So when the atria start to contract, you'll see a little bit of a bump in pressure there. That's due to atrial systole. Then you're going to see a C wave. The C wave is when the mitral valve bulges into the left atrium during contraction. So the C wave is contraction. When the heart contracts, your mitral valve is over here. When the heart is squeezing, there's pressure there pushing it up, mitral valve. So you get a little bit of a bump there as well. So that's the C wave. And then finally you have your V wave. Just know that's ventricular diastole. So we're filling. So the atria are filling, and you get a little bit of a V wave. So V wave is ventricular filling. So you have your A wave for atrial systole, C wave for left ventricular contraction, and then your V wave is ventricular filling or diastole. And we're going to draw all this out so it'll all be there. This is an important part right here, these left ventricular volumes. Left ventricular end diastolic volume, EDV. These are one of the words you got to get in your head. End diastolic volume. This is when the ventricles are filling, right when it's done filling, how much blood is in the heart. Right before it squeezes. So end diastolic. At the end of diastole, how much blood is in the heart? Normally, 140 mLs. Okay, that's how much usually in a normal sized heart, the left ventricle will hold about 140 mLs. When we squeeze our hearts, only about half of that comes out. You can't get all the blood out of your heart. If you ever worked with like any type of like engines before, they have for the gas, you need to prime the pump. You can't go let it go dry, because the pump won't work. You need to have volume of fluid in the heart. You need to have blood there to keep the pump working effectively. So we know that only half of it comes out. We measure that by your end systolic volume. At the end of systole, how much blood is left in the heart? That tells you, if you subtract those two numbers, it gives you our stroke volume. How much blood came out with every beat? This is a very important number because it tells us how well the heart contracts. A weak heart, will it be able to get all that blood out? No. So you're going to see your stroke volume go down because more blood is going to remain in the heart. It can't get out. So your end diastolic volume minus your end systolic volume, we said so your stroke volume is 70. Now, we use this number as a percentage. We want to know of the stroke volume how much, actually left the heart. So usually that is a normal stroke volume. 55 to 60, 65% is a normal ejection fraction. Of the amount of blood in the heart, how much came out? So if I said that your ejection fraction is 30%, that means your heart's only working 30% effectively. You're going to have a very weak heart. That happens after a heart attack. The heart doesn't squeeze as well anymore. So that is your stroke volume. Okay? Yeah?
On the slides on Canvas, the stroke volume is opposite. So mine says ESV minus.
This is right, EDV minus ESV. Yeah. I made changes. I don't know why you guys don't have the right one, so I'll check that when I get home. Ventricular filling is rapid in early diastole, meaning in the early diastole it's going to fill very fast and then it kind of slows down after that. Okay. As ventricles fill, the compliance decreases. What is compliance? It's the stiffness of the heart. How pliable is it? Remember the formula for compliance. It's changes in volume over changes in pressure. We don't want high pressures in the heart. The more compliant the heart is, the more volume of blood it can hold without increasing pressures. As the heart gets very stiff, it can't absorb that pressure anymore, and the pressure starts rising up. That's where you get high blood pressure with a stiff ventricle. Okay? Atrial systole, again, also will contribute to that end diastolic volume. So, formulas to start keeping in your mind. One, I'll put it down here. Cardiac output, or Q. Stroke volume times your heart rate. Keep this in mind because as we start going through this stuff, we're going to be, remember, cardiac output, the Q, is the main homeostatic variable that the cardiovascular system cares about. We need to maintain cardiac output. Stroke volume. What's the formula we just learned for stroke volume? Minus your end systolic volume. So if I do any changes to your end diastolic volume, it's going to alter your stroke volume. Right? What influences your heart rate? Well, what influences the SA node? Nervous system, right? What two types of nervous system goes into the heart? Yeah. So those two things affect your heart rate. So we know that stroke volume normally is 70 mLs. Normal heart rate is about 70. Multiply them together, and we get our cardiac output is roughly equal to 5 liters per minute. 70 times 70 is 4,900 milliliters. I just converted it to liters. So a normal cardiac output is 5 liters per minute. 70 units of blood come out with every beat. We know the heart rate is 70. You multiply the numbers together, and there's your cardiac output. And what we're going to be doing now is talking about ways to alter your end diastolic volume and other things that will alter the stroke volume. So if your heart gets weak and stroke volume goes down, what is your system, what's your body going to do to maintain cardiac output? Raise your heart rate. That's the only way we can get that cardiac output up because stroke volume went down. So let's take a break. We'll come back and we'll draw that Wiggers diagram. Come back at 1:30. Okay, let's get started. Okay, so hey guys, we'll get started. So this is the Wiggers diagram. If you can understand this diagram, going in this direction and working your way down, it's a great thing for this unit as far as the cardiac cycle is concerned and understanding how things work. A couple of things when we get started. When the atria are in systole, the ventricles are in diastole. That's why you see them flipped. And then towards the end, they kind of rest together because that's just the way the cardiac cycle works. But when the ventricles are squeezing, the atria are filling up. When the ventricles are filling, atria are squeezing in systole to get the blood into the ventricles. So they are different there. So let's start labeling the mechanical events that happen during ventricular systole. What is the first thing that happens during ventricular systole? Isovolumic contraction. Remember, this is systole, so we're starting to generate a squeeze. So the first thing that happens isovolumic contraction. You have the real thing on your, already have it in the modules. After isovolumic contraction, what happens next? We get ejection of blood. First, there's a rapid, and then there is a slow ejection of blood. Just happens fast, and then towards the end of it, slows down a little bit. So that is all that happens during ventricular systole. We have isovolumic contraction, and we have rapid ejection of blood, and then slower ejection of blood. This is all occurring during systole. Now, during diastole, just like we had in systole, what's the first thing that happens during diastole? Isovolumic relaxation now. So that's isovolumic relaxation. And then the opposite things just happen on the way out. We have rapid filling. And then finally, slow filling. Everyone good on these 6 terms? So when you're studying, you can go left to right on mechanical events. What are the sequence of events for ventricular systole? Isovolumic contraction, rapid ejection, slow ejection. What are the sequence of events that happen during ventricular diastole? Isovolumic relaxation, rapid filling, slower filling. And then the whole thing just repeats itself over and over and over again. Now, let's look what happens as we start going down. Remember, we're going to be looking at left-sided pressures only. So the only pressures we're going to put on here, atrial, ventricular, and aortic pressures. That's the only 3 things we're going to put on here. So we'll put them in different lines, different colors. So the first color we're going to do is red, and we'll do this as aortic pressure. Aortic pressure during diastole is normally about what? What's your normal diastolic blood pressure? That's systolic. What is the normal diastolic blood pressure? 80. So let's start with 80. And we're right out here. So aorta will be in red. Okay, aortic pressure is in red. During this phase, nothing's happening, nothing's going anywhere. During isovolumic contraction, Does anything happen to the aortic pressure? Nothing's going in the aorta yet. We're still in the ventricle. So during isovolumic contraction, all the doors are closed, right? Aortic and mitral, they're closed. So there can be no movement of aortic pressure during isovolumic contraction because the aortic valve is closed. Now, the ventricular pressure has overcome aortic pressure. Now blood's going to move out of the ventricle. We have rapid ejection of blood coming out of the ventricle. It's going to go into the aorta. If a volume of blood is going into the aorta, what happens to the pressure in the aorta? It goes up. More volume of blood, higher pressures, they go up. So aortic pressure is going to rise, okay, up to about 120. And then it comes back down again because we're slow ejection. Then what was that thing that happens when the aortic valve closes and we have some blood that bounces off the wall? It's called a dicrotic notch. And you actually see that right there. And then nothing happens. And now we're back to where we were the whole time. That's it for aortic pressure. Also known, you can also call it your systemic pressure. Okay, 80, and then during systole, it gets up to 120, and there's your 120 over 80. That's where it's generated from. Any questions about the aortic pressures? Okay, now let's add in our ventricular pressures. And ventricular, we're going to do in green. So, during ventricular diastole, which is where we're still in at the first block, where should your ventricular pressure be hovering around? Close to 0, 0 to 10, very, very, very low. So actually, it starts off there. So it's very, very low. Now, we're in isovolumic contraction of the ventricles during the first phase of systole. What's going to happen to ventricular pressure at this point? It starts to increase. What is the goal of the pressure generated by the ventricle at this point? What number does it have to get higher than? Aortic pressure. So, this green is going to go up, 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 just above the red line. You can see it. Just above that red line. Because right as we're above that red line, then we know we can open the aortic valve. And now we can have ejection of blood. So once we're above it, we're going to stay higher, just above that red line. Okay. We're going to stay right on this line. We're still ejecting blood, so the aortic valve is still open. So this green line is going to hover, 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 and once we get here, we go below that line. Now the green line is below the aortic pressure. What happens to that aortic valve? Closes. Then what is the next step to happen for diastole? What do the ventricles do in the first phase of diastole? Isovolumic relaxation. What's going to happen to our ventricular pressure right now? Going to drop. What does it have to get below to open the mitral valve? Atrial pressure. You see how the pressures change, go up and down depending on what we have to do. So we are in isovolumic relaxation. The pressure is dropping because all the doors are closed, where the heart's relaxing, pressure is dropping. Then we have rapid filling and other filling. So we pretty much baseline right there. We start creeping up towards the end. This is pressure, not volume. We'll have another section in a minute about volumes. We'll see how that changes. We're just talking about pressures right now. Everyone good? Relationships between ventricular and the aortic pressures, how that aortic valve opens and closes. All pressure changes. That's all it is. Now let's add in our atrial pressures. I'll put it in blue. Okay, so now we have atrial in blue. We know that during left ventricular diastole, where is the blood moving from what chamber to the other chamber? Atria to the ventricles. We're filling. So where does the atrial pressure have to be if we're putting blood into the ventricles? Above it. So you'll see the blue line. I'll make it a little thicker. Just above ventricular pressure, and then it goes below, right there. Okay, that blue line went below ventricular pressure right there. What happens to the heart when that drops below ventricular pressure? Closes the mitral valve. Aortic valve was already closed. And that's why we start isovolumic contraction. Because now the pressure in the ventricle, higher than the atria, mitral valve closes. Because mitral valve closes, we get, remember the ventricles are atria are filling a little bit, so they kind of do nothing here. And then it goes down. Oops, I don't want to do that. And then eventually we go higher, and the whole system repeats itself. So if you look, that area and that area, that's where you have crossing over occurring, right? Between different pressure lines. So we can add some more information to this. What happens at that point right there? What valve is closing? Mitral closes, MC. What happens at that point? Aortic valve opens. The aortic valve opens. What happens at that point? Our aortic valve closes, and what happens at that point? The mitral valve opens. So we added some more information to this graph as far as valves. And again, if it's isovolumic, there's no changes in volume, which means that all the doors have to be closed because blood's not leaving the heart, blood's not coming into the ventricles. We have isovolumic, same volume, all doors have to be closed. So if you look at this section, okay, aortic's closed, mitral's closed. Look at this section. Aortic's closed there, mitral's closed there, and mitral doesn't open up until later on. So we need these phases of isovolumic relaxation and contraction to generate force or to relax the heart. Everyone good on the volume, on the pressures and why valves open up and close. Now let's talk about ventricular volumes. So we're just talking about the ventricles. Okay, that's it. So, where are we starting? Okay. Ventricular volume goes all the way up to there. Why is ventricular volume going up? What is happening right now? We are in ventricular diastole. The ventricles fill with blood during diastole. That's why ventricular volume is going up. What is a normal end diastolic volume for the heart? 140. And look where we are. Right at 140. That's why the heart goes up there for that volume. Now, the next phase. What's the next phase that's going to happen? What's the first phase of systole? Isovolumic. Nothing's going to happen to this volume of blood because there's nowhere to go because the doors are all closed. I'm going to put an arrow right here. That point also has another word that we learned before when it comes to stroke volume. What point is that right there, where that black line is? End diastolic volume. This is the volume at the end of diastole. And look at the graph. We're at the end of diastole, so that is your end diastolic volume right there. That makes sense? Everyone understand? Okay, so isovolumic contraction, no changes in volume, but what are we doing in the heart? Building pressure. Now, we have what? Rapid ejection, right? So we're going to drop real fast. Let me change that to... Okay, we drop fast and then slow. What is a normal volume of blood in the heart after systole, or at the end of systole? 70. Look where we are. Right around 70. So we drop to 70. This point right here is what? End systolic volume. That makes sense. Okay. Now, what's the first phase of diastole for the heart? What does it do? Isovolumic relaxation. So is the volume of the heart going to change right now? Nope. So we'll go back to read. We're no change. All the doors are closed. Can't go anywhere. And then, our pressure in the ventricle has dropped below atrial pressure. Mitral valve opens. Blood starts to come in now. So we're going to fill. So our blood volume now goes back up again, and it starts to creep up. First it's fast, and then it gets up there again. Kind of waits. No, let me just change that. And it works its way back up again to repeat the cycle. So that's ventricular volume. So these graphs are to reinforce concepts and understand where we get these numbers from. I'm not going to ask you on an exam what's the number for ventricular isovolumic relaxation. It doesn't matter. But know what it is. Know where it happens in the cardiac cycle. Why is it important? What are we doing? We're generating pressure to open up your aortic valve. So the last thing we'll do is heart sounds and the EKG. Heart sounds. We'll do it in red. Okay, when it's in the heart, S1 happens right here. You hear one sound, S1. What valve event is happening right at S1? Mitral valve is closing. So when you listen to a heart, the first heart sound that you hear is just the mitral and the tricuspid valves closing. That's all S1 is. Mitral tricuspid valves closing. S2, so there'll be no sounds. And then here is S2. What valve event is happening at S2? Go up and down. Look at S2, go straight up that line. What aortic valve is closing? So your aortic and your pulmonic valves create S2. And that's all those valves are. Every heart sound that you hear is just the valves closing. That's it. So S1, mitral and tricuspid valves are closing. S2, that lub-dub. The lub is your mitral, your atrioventricular valves closing. The dub, the S2, aortic and pulmonic valves closing. So those are your heart sounds. You have a couple of extra heart sounds in there, but we're not going to deal with it. Okay? Last thing, EKG. And we'll see how this excitation contraction coupling works together. So in this case, because of how it's set up, the P wave is kind of split between two sides. So here's our EKG. We have the beginning or the trail end of the P wave here. Where is it? Then when it hits here, what event is happening when we hit that dark black line? What's happening? What event? What mechanical event is happening when we hit that line? Ventricular systole, ventricular contraction. What has to precede every ventricular contraction? Your QRS complex, which is ventricular depolarization. And there's your QRS complex because it lines up with ventricular contraction. Remember, we have excitation, contraction, coupling. You have to excite it first, and then the event happens. QRS complex happens, then we start our isovolumic contraction, ejection, all because of the QRS complex. Then nothing happens, but right at the end of systole, we have our repolarization. So here's our T wave, which is repole of the ventricles. And then nothing, and then towards the end, we have the beginning of our P wave again. So when you're studying, I know it looks like a lot. Break it down just like we did. Take it, okay, what is occurring during isovolumic contraction? Just work your way down. What's going on with the valves? What's going on with isovolumic relaxation? We know the valves are all closed because isovolumic. What's going on during rapid ejection? Why does the mitral valve open? Why does it close? Know these things. Remember, pressure changes cause all these changes to happen. Okay, so this Wigger's diagram summarizes everything we've kind of learned so far, puts it all together on a nice table. Okay, you have on Canvas, you have blank copies of this, and you have the real printed versions. So to study and kind of work through, this is a really, really good diagram for that. So here are the heart sounds. We talked about this a little bit before. The lub dub, S1 is the lub, S2 is the dub. These other heart sounds, this is for the PAs when you start doing your cardiac exam next week. There's a split of S2. Sometimes you'll hear on inspiration. So when you breathe in, you'll hear that S2 split, and you'll hear it on exams. You can hear that's a normal finding, guys, so you'll hear that in everyone. S3 has to deal with a stiff ventricle, which is non-compliant. So stiffness. If I have a stiff ventricle and I'm putting blood into it, it's going to make a sound. Okay, basically what happens when if this is my ventricle blood's hitting the wall. Makes a sound. That's what S3 is. Because that atrial kick is trying to get that last little bit in there. Oh, no, I'm sorry. Stiff ventricle, the blood during diastole, the blood's going to hit it, causing S3. In S4, it's an atrial kick. Remember, right at the end of atrial systole, we have that atrial kick. And sometimes when you need it, like during exercise, it makes a sound. It's called Kentucky, is an S4. So whenever you are listening to these things, Tennessee is S3. The ten is S1, S2. The C is S3. For Kentucky, the tuck is S1. The E is S2. But the Ken is S4. Kentucky is S4. So it's a way to memorize those things when you get to physical exams. Okay. This pressure volume loop. This is another way to interpret the left ventricular cycle. We do it with this pressure volume loop. We talked about this a little bit yesterday when it comes to compliance. Okay, so what I'm going to do is we're going to draw that compliance line. Okay, we're going to call this A. We're going to call this B. We know that segment AB is our compliance line. Okay? I'm just going to draw this out totally. Okay. We're going to talk about this as it relates to the cardiac cycle with the left ventricle. From A to B, what is happening to left ventricular volume from A to B? We're filling. Okay, well, we go in this direction. So we go A, B, C, D in that direction. So A to B is compliance, but we know that's also filling. Because compliance issues are filling problems. So we know we're filling right now. When we get to B, from B to C, what is occurring? Is there any changes in volume? But what is changing? Pressure. Pressure is rising. What phase is this also known as? Isovolumic contraction. Right? Our volume is at 120. It's not changing. We're going straight up. But the pressure is changing because we're generating pressure. So at point B, the mitral valve, is it closed or open? Let me change the color. Remember, what are we doing right now? It's isovolumic. Everything's got to be closed. Mitral is closed. Aortic is closed, right? Now, we're generating pressure in the ventricle. We're going from B to C. At point C, what is going to open up? The aortic valve is now open. Is the mitral valve open or closed at this point? Closed. So the mitral is closed. So now we're moving from C to D. What is happening to our ventricular volume from C to D? It's decreasing. Where's the blood going? Aorta. It's going to the body. Remember, this is all dealing with left ventricle. So from C to D, blood's moving. We're flowing. So aortic is open, mitral is closed. When we get to point D, what's our valve situation now? Everything's closed. What's going on from D to A? This is your isovolumic relaxation. So B to C is contraction. C to D is ventricular ejection. D to A, isovolumic relaxation. And then finally, A to B is also compliance, but we also know it's ventricular filling as well. We are going to use this graph a lot to describe a lot of different changes to the parameters that affect stroke volume. So we're going to refer to this graph a lot. So really understand what's going on with these different phases. So at what point would you know where end diastolic volume is? What point is end diastolic volume? Who thinks it's A? Who thinks it's B? Who thinks it's C? Who thinks it's D? Okay, B is correct. B is your end diastolic volume. Remember, this is diastole. We're filling at this point. So point B is your end diastolic volume. What letter would be our end systolic volume? D. That's our end systolic volume. So, the last thing we can get from this graph is our stroke volume. Stroke volume is just the distance between the two lines. As we go through different examples dealing with this graph, the purpose of that line for stroke volume is just to look at the width. If that width of that stroke volume line is getting smaller or more narrower, that box is getting narrow, we know our stroke volume went down. If this box is getting wider, stroke volume is going up. We're going to be altering these things and defining them in a different way very, very soon. Everyone good on this pressure volume loop? Okay. So let's talk about cardiac output. Cardiac output is a flow. That's why it could be Q as well. So cardiac output, CO, Q, it's flow. It's liters per minute. That's your cardiac output. How many liters per minute can you get out? What's a normal cardiac output? 5 liters per minute. Remember, it's 70 for the stroke volume, 70 for the heart rate is 4,900, so it's about 5 liters per minute. And that's the equation for it. Ejection fraction we talked about, usually 55 to 65%. Why this is important? Because when we talk about heart failure, you have to classify the heart failure. If they have heart failure where the ejection fraction is preserved, we know that's diastolic failure because they have a filling problem. If the ejection fraction is reduced, that's a systolic problem because that's a squeeze issue. That's systolic dysfunction, which is the old way it's called. Cardiac index looks at cardiac output as a reference as it relates to your body surface area. This is a normal thing in the ICU. They want to know this. They want to make sure that you have enough cardiac output to perfuse your entire body. So looking at body surface area versus your cardiac output, is it enough to perfuse your body? In the ICU is where this is important because they're going to have hemodynamic instability, and you want to make sure that cardiac index is high enough that they're able to keep all their organs working and whatnot. So that's where cardiac index comes into play. Now, Frank Starling principle. So all your ex-phys people should remember this one. So this is contractility. This is the relationship between stroke volume and end diastolic volume. When we talked about skeletal muscle, the contractility is fixed in skeletal muscle. Why is our contractility fixed in skeletal? They're fixed to the bones. The heart is not fixed to anything. It's just a sac that just sits there. The great thing about our hearts is that the more calcium that's in there, the bigger the contraction is going to be. As the heart stretches, because more blood's going into it, more calcium comes out to have a bigger contraction to get all that extra blood out. So as we stretch, meaning in the heart, think of the heart as a water balloon. If you add more volume of water to the water balloon, it's going to get bigger. Hearts get bigger too. There's going to be more stretch. When that happens, troponin becomes very sensitive to calcium, so we get really good binding in their cross bridges, and we get a very forceful contraction. So here's stroke volume, here's end diastolic volume. This is the normal way we want to see it. With a certain end diastolic volume, you have a bigger stroke volume. The bigger the stroke volume, you keep changing the lines from there. So just know, end diastolic volume is the biggest predictor of stroke volume. Meaning, the higher the end diastolic volume, the bigger the contraction is going to be. It's the biggest one. So end diastolic volume is the biggest predictor of stroke volume. Now, with this line right here, as you increase contractility, this line shifts to the left. If you decrease contractility, the line is going to shift down to the right. And how do we know if contractility is good? What's the number we're going to look at? What's the variable that we just looked at? Not end diastolic volume. On an echo, we can get it. Ejection fraction. That's what we want to know. What's the ejection fraction? What's a normal ejection fraction? 55 to 65%. Half of our blood comes out every beat. So as that number goes up, the stretch goes up, bigger the squeeze. Okay, star this one, highlight it, whatever. You got to know these three terms. Preload is created by your end diastolic volume. So end diastolic volume and preload are the same exact thing. It's the weight or the pressure on that resting heart. In the skeletal muscle, it's when you have a dumbbell in your arm and you're holding it. That's a preload. You are preloading your muscle. Your end diastolic volume, which is determined by your venous return, the blood coming back to the heart. Venous return will determine your preload. What is in the heart right before it squeezes? That is preload, also known as end diastolic volume. Afterload. When we talked about isovolumic contraction, what are we talking about? What actually is going on in the ventricle? What is it trying to do with isovolumic contraction? We're trying to overcome aortic pressure. That is what the afterload is. We're trying to generate enough pressure, which is the afterload, to get out of the heart and open that aortic valve. When you're leaving today to go outside, it's windy out there, those front doors sometimes are heavier to open up. When you put your arm on a door, but you don't push it, I'm just waiting. I'm not moving the door. This is preload. Okay, I have tension on my arm from the weight of the door. Now I have to overcome the weight of the door to push it open. That is the afterload. The heavier this door is, I have to generate a higher afterload to get it to move, right? That's what happens with high blood pressure. High blood pressure will influence afterload, any factor that opposes ejection of blood during systole. Systemic vascular resistance, total peripheral resistance. We'll get to that in a little bit. They're all the same thing. It's the force that the heart has to generate to overcome aortic pressure. So, in a normal blood pressure, the heart has to generate what afterload to get out of the heart? What's the normal systolic number? 120. So the heart will just continue to generate 120. We can open the aortic valve and we're okay. if your blood pressure is 160, that 120 that the ventricle is going to generate, is that enough to open that aortic valve? No, because your systolic blood pressure is 160. So what does the ventricle have to do now? Generate more pressure to get above that aortic valve. The heart is a muscle, just like any muscle in the body. If you work that muscle too hard, in skeletal muscle, you want that hypertrophy, you want that muscle growth. You don't want that muscle growth in the heart. Thick hearts don't work well. Long-standing blood pressure increases your afterload. So instead of having to generate 120 millimeters of mercury of pressure with your heart, now you have to generate 180, let's say, for every single beat. That puts a strain on the heart. The heart's going to hypertrophy, and you're going to get heart failure later on. And that is why we're so big on blood pressure. Okay? Getting blood pressure under control. Because if you have high blood pressure for years, that means that every single beat, your heart is working harder than it has to. And it's going to get thicker, and it's not going to work well. That's where afterload comes into play. The last one is your contractility. We talked about that Frank-Starling curve. Again, the bigger the contraction, the more forceful and more blood's going to come out. So that's all contractility is. So these three words you got to know again. Preload, afterload, contractility. Preload, end diastolic volume. For every little bit of volume of blood in the heart, there is a pressure with that. That is your preload. What pressure is on the heart based off of the volume of blood that's in it. End diastolic volume. Afterload. How much pressure does the heart need to generate to overcome the aortic valve? And that's your systolic pressure. Contractility is just how well the heart squeezes. So, preload. And I'm going to draw out our pressure volume curve again. Here's our pressure. Here's our volume. Okay. Everyone good so far what I just drew? This is your basic pressure volume curve. Same exact thing we just drew before. Now, I said before that preload is really your end diastolic volume. So at what point is our end diastolic volume? B. So we can now label B as preload. Which is also end diastolic volume. Okay. So, let's screw around with our preload. Let's alter B. Let's say we're working out, we're exercising, our cardiac output's going to go up, our venous return goes up, blood coming back to the heart also increases because we need more blood going around. So let's say we change B to there, and we put it out here. We put a new dot, we call it B prime. We're increasing our preload, right? If you increase end diastolic volume, the preload goes up. Now, let's draw the new box. We still start from the same area because the starting amount of blood is going to be the same. Okay, we're going to follow the red line. We're going to go all the way out now to the new B prime. C remains at the same level. We connect back with this line and we go down. Now, let's look at our stroke volume. What happened to our stroke volume when we increased the preload? Increased. So we have a new relationship now. Increased preload leads to increased stroke volume. They're in a proportional relationship. If you increase the preload, you're going to increase your stroke volume. What's the chemical reasoning of why an increased end diastolic volume, an increased preload, increases your stroke volume. What happens when that heart gets stretched? More sensitive to calcium, a stronger contraction. So we can get more blood out. Okay? These are some things that will enhance your preload. Remember, preload is also your venous return, the blood coming back to the heart. Skeletal muscle contraction. That's your muscle pump. Keeps those veins squeezed so the blood moves up. When you're running, that skeletal muscle pump works a lot more, increases and enhances blood return back to the heart. Deep inspiration, we'll get to a little bit later on, but when you breathe in deep, it reduces the transmural, or your intrathoracic pressure drops from a big breath in, and it acts like a suction, and the blood just kind of flies right back into the right atrium. Atrial systole, venoconstriction. What is venoconstriction? Veins. Do not confuse that. Read that word, veno. If it says vasoconstriction, it's usually going to be an artery. But when it says venoconstriction, it's a vein. So if you increase the constriction of your deep veins in your legs, which way is the blood going to go? Back to the heart. That's what those are talking about. So that's preload. Positive relationship. You increase preload, stroke volume goes up. So why is preload so important? We can alter preload at bedside very quickly. Trendelenburg position. What's Trendelenburg? Feet up. So which way is gravity pushing the blood? Back to the heart. Increasing venous return. Increasing end diastolic volume. Increasing preload. Increasing stroke volume. Increasing cardiac output. When you're studying, put these things together. What's the step that's going to happen? Okay. Don't worry about the rest of it. IV fluids, obviously, if you're giving fluids to someone, you're increasing their blood volume, increasing the blood return to the heart, increasing preload. Take these steps. What's the next step? What's the next step? What's going to happen next when you're studying the cardiac stuff? Afterload. Like we said, BP is used as the index of afterload. The higher the blood pressure, the higher the afterload. It's the resistance to blood flow by the circulation. You will see this written differently. They both mean the same exact thing. You may see it systemic, vascular resistance, SVR, or total peripheral resistance, TPR. They are the same exact thing. If they increase, it means your blood pressure went up. Afterload goes up. Also, stenosis of your aortic or pulmonary valves, which we'll get to later on in pathology. So, let's draw out our pressure volume loop again. So we said before that B was our preload. Let's look at A. I'm sorry, not A. From B to C, what is going on from B to C in that segment? What are we doing? Isovolumic contraction. And what are we trying to do with the pressure generated from this isovolumic contraction? We're trying to overcome aortic pressure, which is also known as afterload. Remember, overcoming pressure that opposes blood leaving the heart. Afterload. So C is afterload. Okay, so remember also, here's our stroke volume. So, the way it works now, we're going to move C up. to C prime. Because we're increasing the afterload, right? We're going to make it go higher. We need to generate more pressure to open the aortic valve. So before we were at 120, now C prime, let's say it's 150, 160. It doesn't matter. The number went up. We increased our afterload. When we do this, we go up to C, because remember, the cardiac cycle is a timed event. You only have a certain amount of time to do each of these phases. If we're spending more time generating pressure in isovolumic contraction, if we have to spend more time because we have to get higher due to afterload, we have less time to get the blood out of the heart. You only have 1 second to get this all done. If I'm spending more time generating pressure, I have less time to get it out. So therefore, what happens is the whole thing changes. Now look at our stroke volume. What happened to our stroke volume as we increased our afterload? Decreased. So if you increase afterload, you're going to decrease stroke volume. And these things here are ways to alter your afterload. So if you reduce your afterload, what happens to your stroke volume? Goes up. That's why we give blood pressure medication, to get your blood pressure back down, to reduce the workload on the heart, to make it work easier. Okay? So afterload is an inverse relationship. If you increase afterload, you're going to decrease your stroke volume. So again, this graph is just proving to you, yes, that it all works. I think we're done. Okay. Contractility we talked about before. So this contractility is actually point D. It's an imaginary line that we really don't put on that graph, but wherever D is the contractility line. It's this Frank Starling right here. So if you want to make this D, you can draw this. Here's A, B, C. And if we increase contractility, D prime is now here, and you'll see how that changes in a second. Contractility, again, difficult to define an intact heart. Left shift in this Frank-Starling relationship, increase greater contractility. So if this line shifts left and up, we've increased our contractility. If that line shifts right and down, we've decreased it. I think this is the end of it. Yeah, we'll finish that later. So again, pressure, volume. Remember, D is our contractility. If we drew an imaginary dotted line, that's that Frank Starling curve, that green one that I put in there. But we just assume that it's always D. So D is always contractility. If I shift this line down because the contractility got worse, because we had a heart attack, whatever, here's our new D. So here we go just to the line. We go down and up. So you see stroke volume. If you decrease contractility, what happens to your stroke volume? That's wrong. Decreases. If you increase contractility, you increase stroke volume, which just goes along with the whole preload. Remember the bigger stretch? Okay? So that is contractility. Again, these are just proving to you why those things work, to reinforce that idea. And we'll finish up the rest tomorrow. Guys, one more thing. Tomorrow, we have EOR. So the third PA school class is going to be here. So there's going to be another 60 cars in the parking lot. So parking for the next 2 days is going to be crazy. Warning you all now. Okay? I'll see you guys tomorrow.